Our autumn partners event is often a time of reflection, and tonight we're going to discern some learning from the challenges that we faced and see what that means for our future. How have we done? Have we got the balance right? What does it mean for our model? Is autonomy still the right thing for us? And how's that got us ready for our future challenges? In fact, what are our future challenges? Tonight's divided into 3 parts. You can hear some learning from the board. You can have a thought piece from Victor about the challenges that face us. And then, importantly, perhaps, the time to network, share with colleagues, and get the energy in the room to think about the things that we want to talk about. You'll also have the opportunity to check in with the team if there's any issues. We've got some partners here with us tonight, Ardens, Livy, Hempsons, who will be available for a chat. And perhaps most excitingly, we're going to have a learning and sharing exercise. So we've got practices that are sharing some of the innovations that they're doing across the partnership. So I'd really recommend connecting with them. One of the things that's probably quite important for me is capturing your feedback from each and every one of you. So there should be postcards on your tables, and I'd like to get 3 things from each of you, if that's possible. Firstly, what's going well? What are you proud of from an OHP perspective? Secondly, what can we improve? What should we be paying renewed attention to? And thirdly, what new developments would you like to see? And each of these will help inform our Year 2 to Year 5 business plan once the politics has settled down. Over the last few years, we've had an unprecedented time of change for general practice. We had the workload, workforce and funding issues that resulted in the GP forward view. And that was meant to be a fix, but in fact things have worsened since then. But as OHP, we managed to use that for collective impact. STPs were born without having a clue what general practice providers were meant to do with it and to it, and for it perhaps. But in Birmingham and Shropshire, we managed to create a GP voice within our STP for OHP practices and beyond. And more recently, the NHS long-term plan was born, and with it, integrated care systems and primary care networks. OHP managed to influence the offer and co-create a solution with you. And we saw networks coming about 12 months ago, so we radically changed the shape of the organisation in readiness so we can deliver for all of us. All to make life easier for our practices and our partners there, so we can maximise the impact for our patients day to day. And from my perspective, we've created something that strengthens practices, and at the same time created an organisation greater than the sum of its parts, so we're stronger together now. But it's not always been perfect. So what have we learned? I'd now like to introduce the new board that you see before you, particularly welcoming Helen, Paul, Gavin, Julie and Dan, and hear what we all have to say about the challenges that we've faced, and hopefully they'll keep to 2 minutes a slide as we go through the next few things. So first of all, Gavin.
No, I get my microphone held actually, such is life. Good evening everybody actually. I'm already wishing I'd done a bit more preparation. I figured on a November evening in West Bromwich Albion with a terrible road traffic accident and the road shut, actually there'd be about 3 people. I could just sit down at the table and say, these are my notes, have a quick look. But anyway, thanks very much for coming. So autonomy versus integration, this is what we were discussing last time, and we've done a survey about what you thought about it, and Leslie has prompted me to remind you that the findings of the survey are on your table should you want to have a quick look at it. So when we started, it was very much about autonomy. We wanted to be in a big organisation, but we wanted to do absolutely pretty much everything ourselves. And last time it was suggested that maybe now we're a more mature organisation, maybe we're moving towards being a bit more integrated. And certainly the results of the survey would kind of support this. So at a practice level, we're looking at trying to do things in a more similar way. Why have unnecessary differences? PCNs would seem to be a good place to maybe start that process. So maybe sharing budgets, sharing teams around a sort of geographical basis. And across the whole organisation, the mood seems to be maybe acting more as one, though not necessarily becoming one whole, huge, humongous organisation. And one of the things that I hope to do in this new role is to actually sort of seek your opinion a bit more closely on this as to how we might bring ourselves together a bit more closely and get the benefit of being a larger organisation made up of smaller units that may in time become larger units. Thank you very much.
Thanks, Gavin. So in the next 5 slides, I don't think I've got working right now. In the next 5 slides, we have the following themes that we thought we'd like to share learning for you. So first of all, what we've learned from research and some of the work we've done nationally, Bhavna.
Good evening, everyone. Lovely to see you all. So I'm briefly going to talk to you about some research feedback that we've had and just a national profile of OHP. In 2016, a research group from Manchester University approached us because they were looking at reviewing different partnership models, federation models. So we agreed to be part of this. I believe we were one of 3 models that they looked at. It's all anonymous, so I couldn't tell you who the other 2 are. And they attended several board meetings, GP Forward View meetings. They visited some practices, spoke to partners, spoke to practice managers. So they had quite an in-depth look at our model and how we function. We just had the verbal feedback from them last week. And their feedback to us was that we have collective ownership. We have collective ownership of problems. We share solution findings. And within our model, there seems to be a higher degree of independence in place. They did comment that we are the only model that can adapt and change to the benefit of our partnership. And we all felt that this was really positive. They have stated that the actual findings of their research will be published in December. As soon as we get that, we will forward it all to all the practices. From a national profile point of view, in January 2019, Nigel Watson published his partnership review. We were one of the case studies that he did look at. The key results that he identified were that OHP model, again, was very flexible and he found quite innovative. In January 2019, the NHS long-term plan was launched. Vish was an external advisor for the creation of PCNs and had quite a big influence in how PCN structures have been formed. Before I leave you, I just want to briefly mention the Caring for Doctors, Caring for Patients, and this is a recent publication. In 2018, the GMC asked Professor Michael West and Dame Denise Coyer to carry out a UK-wide review into the factors which impact on the mental health and well-being of medical students and doctors. We have printed off copies of the executive summary and it's on all your tables. I think it's a fascinating read. The entire document is 151 pages, so you might not want to do that one. Patient safety depends on doctors' well-being, and that was a big theme throughout the publication. One of the things they mentioned was that this research or review looked at doctors but can be extrapolated for all our staff in the NHS. They came up with something called the ABC of doctors' core needs. A stands for autonomy and control, and they have said the need to have control over our work lives and to act consistently with our work and life values. This seemed to be a very core fundamental need for doctors as well as other staff. Belonging, the need to be connected to, cared for, and caring of others around us in the workplace and to feel valued, respected, and supported. Competence, the need to experience effectiveness and deliver valued outcomes such as high quality care. And all of these really resonated with me and struck a chord, and I do believe that in OHP we're already working on this, and I do think as an organisation we are quite strong, and this needs to be a core value for our doctors and all our staff. I think we're already using this quite well, and it's helping us to successfully overcome challenges we face. And I'll pass you on to the rest of the team to see how we're doing this.
Great, thank you, Bhavna. So a lot of that was based on Michael West's work, and he's an advocate of something called compassionate leadership, if you've not come across it, and I really think that that's worth a quick Google if you have the time. Kate, what have we learnt from CQC? Kate and Dan.
Well, our CQC journey really started in March 2 years ago when Clarity TeamNet, or GP TeamNet, that was initially called, was procured for all of our practices, and I think we're all using it now, and I hopefully find it extremely useful and helpful. July of that year, OHP was approved as a provider at scale by CQC, and by September, all OHP practices were registered under a single CQC registration. In December last year, the CQC conducted an inspection of OHP Central, and we had some very good feedback from them on that. And in the following 3 months, up until March, 21 practices have been inspected. Now we've started the annual regulatory review process, so all practices who've received an overall good inspection report can now have, basically it's a telephone interview, and it's conducted centrally by the OHP team with the use of the practice manager available, and we've had 6 of those so far. But that is dependent on having a good CQC inspection report and also maintaining that, because if there's anything that they don't like in the AAR, they can come and inspect you. But it does release us from that burden of knowing that we're going to have a full inspection every 3 or 4 years.
Thank you, Kate. Yeah, all I've got to add is, after what Kate said, is single CQC registration. The single voice gives us the ability to influence CQC. For practices, the admin support from OHP Central, introduction of GP TeamNet, the GDPR support from Kate, from Naomi and Leanne, as well as the preparation they provide for our CQC inspections. And then the on-the-day attendance of Naomi and Leanne, I think for those that have had inspections, is fantastic. And then going forward, on the annual regulatory reviews, we've still got CQC leading, which is, I think, is all a big plus for us. Thank you very much.
Thanks, Dan. And how about some of the patient-facing services? Alex, what have you learned from the extended access service?
Thanks, Rich. Good evening, everyone. So I just wanted to give an update on the journey that we've been on with extended access. So it started in May 2018. We were given very tight timelines to open extended access hubs. Pete's nodding. For all of our patients, and this presented a huge challenge to OHP as an organisation. We had to mobilise very quickly. We had to develop shared records access. We had to work very much in collaboration with the hubs and with the hub leads. And that has really continued. We managed to open all 7 hubs by the 1st of October, which was our deadline. Some of the hubs actually managed to open before that. And the hub leads have continued to work together, meeting on a regular basis to share best practice. And as you can see, we've actually sort of delivered over 92,000 appointments in extended access hubs since they opened. These appointments are available 6:30 to 8 p.m. on weekdays and on Saturdays and Sundays, and there's a range of clinicians involved, so GPs, ANPs, some hubs are using phlebotomists or healthcare assistants, so really a wide range of appointments. More recently, in August of this year, we started our partnership with Livy actually started well before that, but the project went live in August at one of the hubs. And since then, we've had a large number of sign-ups, so over 5,000 patients have signed up to the Livy app, and 840 appointments have already been delivered through Livy, so that's video consultations. And Livy are now delivering 12.5% of our extended access contract. What we've also negotiated is that over Christmas, the hubs will not have to physically open, so Christmas Day, Boxing Day and New Year's Day, all the appointments are going to be delivered through video, and I think that's going to be much better for our sanity, and hopefully pretty good for the patients as well. I thought it might also be helpful just to share with you a couple of the comments that we've had from patients who've used the service. So one patient who suffers with MS and gets recurrent UTI said that being able to have an appointment on a Friday evening without having to attend surgery has really sort of been a massive benefit to her. So she managed to get her prescription for antibiotics through a Livy consultation, and that saved what would have been quite a difficult time for her. Another really useful comment was from a busy mother who said that being able to have an appointment on a Sunday evening meant that she didn't have to contact her GP surgery on a Monday morning. And I think that's something we could probably all identify with. So really in summary, just to say that the extended access hubs are going really well. We're moving ahead, and we're making a success of it, and that's thanks to all your hard work and the work of the team at OHP. And actually, we want the extended access hubs to be part of the system solution in terms of access. And there's some negotiation ongoing at the moment to possibly have some extra activity come through the extended access hubs. But I'm not going to say any more about that tonight because we're going to send that out in a further communication. And that's all I've got to say about extended access.
Brilliant, thank you, Alex. So some really interesting statistics there about extended access and what we're doing. So digital is entering our consciousness, Gavin, and what are we learning from it?
It's pretty vital stuff, I think, actually. So I'd start worth repeating that Alex mentioned. So we've got 5,000 people or so signed up with the Livy app. And when I prepared for this little bijou talk out, there was only 500 consultations having taken place, but already in that short space of time it's gone up to 821, so it's obviously a good upward trajectory. So we're partnered with Livy, which is great. So they've got a really nice website and fantastic pens, but you know, they're not absolutely perfect app themselves. There's still room for improvement. So when you log on, it's a bit of a faff, or maybe that's just me. Then when you actually do the screen consultation, you know, the picture that you get of the person that you're looking at, because half the screen is a little bit of history that you get, which is really jolly useful, but the screen itself is quite small, so you have to kind of squint and see what they really look like. So that could be improved. So when you FaceTime someone, you get the whole screen. Also, you know, it's quite difficult to book an appointment at the moment. Your reception staff can't actually book the appointment yet. You've got to get the patient to download the app, use the app, and then book the appointment. So then you have to check to see if you've actually got appointments booked in your surgery. And Livy texts you that you've got surgery even if you've got no people booked, and you get all worried. So these are teething troubles. But what I can say, I think it's a vital partnership, and it's going to be very useful for us. So a little anecdote. A few weeks ago, I got a text from Dave Rosser asking me to be part of an interview process at UHB, interviewing the new GPs that are going to be working in A&E there for the people sort of attending with GP type problems. And it was other than myself actually, it was a very high powered sort of committee. He was there, the medical director was there, the associate medical director was there, they pitched up an A&E consultant, they had the top management person for that particular line. And then this was only for 4 applications. One of whom wasn't particularly good, because his opening remark to my question was, and why are you interested in this particularly unusual, interesting job? And he said, well, I live quite close to the QE and it'll cut down my commute. So I think even he was thinking that probably wasn't right to say it. But anyway, the other person at the interview committee was the medical director from Babylon, who I tried hard to hate actually, but he was a really nice chap, ex-Birmingham graduate, and I had a chat with him later. And I said to him, well, you must be a bit disappointed. There's been this massive advertising campaign, and you know, everywhere you turn, it's Babylon and GP at hand, and you've only got 1,500-1,600 people registered. Surely that's not brilliant. He said, no, it's good. You know, we've got a toehold. You know, freshers will come around next year. We'll get a load more people, and it's just going to build from there. So I was telling him about Livy, and he said, no, that's quite good actually. He let slip that he felt that any practice who were offering video consultations, they would be fine. They would be able to ward off Babylon. But the ones who haven't got that facility, he said, to quote him, we'll probably just hoover them up actually. So I think, we're in a good place. We've got some work to do, but it's going well.
Thanks, Gavin. So great start, but maybe changing it towards a digital extension of our practices and a real plea for all practices to consider offering a digital solution that's there for you. So, Helen, Jenny, what have we learned from the creation of PCNs?
Well, we're really proud of how OHP is supporting the development of PCNs. They have come about through a really tight timescale, and we have had a massive head start in developing our networks, which we started last autumn. Which helped to prepare us for PCN delivery in July. So the benefits of having 11 supported practices across Birmingham and Shropshire is that we're learning from each other. We are supporting our clinical directors with development and structure, and this is taking the pressure off from the individual practices and PCNs.
So, what does it mean for practices? It means that the central OHP team, been batting on our behalf, with the CCG completing the maturity matrix required to trigger development funding release for the PCNs. It means that contracts have been negotiated with the Active Wellbeing Society and Shropshire Council to giving us a head start with appointing social prescribing link workers across our PCNs. And we're also proud to have appointed a consultant pharmacist, Claire Huckabee, who's sitting down there, who will support the development of our PCN pharmacists across the whole group. And I think that the brevity of this shouldn't undermine the importance of these developments.
Thank you, Helen. So a real base of stability and commonality, allowing us to really develop services that focus on our local populations. So Gavin, what does this all mean for our challenges, our future?
Sorry, it's me again. I think I've got the short straw here, actually. So, digital general practice. Even an old person, timer like me, actually, we live in a digital age. Actually, we live in an app-based society. If you talk to, anyone from about 20 to 45, if you ask them, well, given a choice, would you like to spend 25 minutes trying to get through on the phone, book an appointment that doesn't really suit you, take an hour or so off from work to drive in, find there's nowhere to park on a nearby street. It's then started to rain, so you get wet walking to the surgery, then sit next door to some kid who's coughing all over you for about half an hour because the GP's running behind time. You then have an appointment for 10 minutes, but you can only deal with one problem because it's a really busy day. And then you go back to work, and the whole thing's taken 2 or 3 hours out of your life, and it's not been that great an experience. Or you could, on your phone, speak to that same GP, without leaving your kitchen or your workplace, without travelling, without increasing your carbon footprint by your very large, sports utility vehicle that you drive into Lordswood and then find nowhere to park. You're going to go for the latter, aren't you? So the future, even though we probably don't like it, given the choice, we would much rather have the traditional model where we get up, we ask people to come into the waiting room, we see what they're like when they're walking in, we're face to face with them, we get all the non-verbal visual clues. Things are changing. We're going to be doing more stuff by video, by phone, probably by email, probably by text, and that's just a world we're going to have to get used to. And that's why we need Livy, that's why we need this technology to help us along. So urgent treatment centres. I think I've probably been hearing about these since I was about 5, but I believe they are due to actually happen, actually. They are coming a bit like Christmas. So it's good that we should be involved with them because we weaken our profession, we weaken general practice, we cut off bits of what we do. So it's a bit like the home visiting thing that the conference of LMCs in its wisdom has decided that they want to get rid of. I mean, it's a profession, I think, has shown great marksmanship, actually, not just shooting itself in the foot, but shooting itself in its tiny brain. It's an open goal to the government, actually. We shouldn't be sort of getting rid of such an important part of what we do. We should be getting rid of the crap that allows us to do the important stuff. Anyway, I digress. Urgent treatment centres are on the case. So tackling health inequalities. And, well, it sounds a bit like revising for MRCGP, and this has been going on for ages, and it's not getting any better. And it's the right thing for us to do, absolutely the right thing for us to do. But obviously you're kind of thinking, well, I'm already, up to here with stuff. So the way we need to do that is in an innovative and different way by probably engaging to work with us, organisations that we're not familiar with and don't really know much about. And tackle these sort of non-medical or medicalised problems in a way that we're currently not doing. So we're very lucky to have Lord Victor with us this evening. I'm going to hand back to Vish to do a more fulsome and detailed introduction.
As I do so, I'd like to just remind you all to write down your feedback. So what are you proud of? What could be better? What would you like to see as a new development? Because we'd like to capture that from each and every one of you as you go out. But Victor, it's been great spending the afternoon with you. Lord Victor Adebowale CBE is kindly taken the time to come and speak to us. He's uniquely placed to challenge and inspire us as we think about our next phase of development. He has been on the board of NHS England nationally. He is a health tech entrepreneur, and he started and continues to improve the lives of many, many thousands, hundreds of thousands of patients with health inequalities. Victor.
Let's crack on. Thank you very much. It's kind of you to invite me here. Me and your lawyer will be yeeting it out of here at 9:15 because we determined to get back to London to see our wife and kids before they forget what we look like. I'm going to talk for, 15 minutes or so, 15, 20 minutes, and we'll have questions and all that sort of stuff if you want. I've got time for 2 questions, then I'm off. And very nice of you, Vish, to we've got a deal actually. We don't use our whole titles. We just call each other Vish and Vic. So, and I always say that since I'm amongst friends, you can all refer to me as Professor the Lord Victor Adebowale CBE. So I want to say a couple of things. First of all, I agreed to do this because Martin introduced me to Vish. And me and Vish got chatting, and I don't impress easily, but I was impressed by Vish actually. I hope that's not embarrassing to say that, but I generally would avoid coming out to West Bromwich on But I thought actually you're onto something here. And I'm going to explain to you why in a minute. The thing that struck me about Vish was just the model of leadership that he was actually not talking about, but actually being, because leadership is about being. It's the emotional investment in the outcome which separates it from management. And the kind of leadership that Vish kind of expressed in his communications with me was kind of humble. It was humble, it was human, and it was about system leadership. It was about learning on behalf of the system. And so and I guess, I'm not saying that this is the absolute reason why you are as successful as you are, but it's one of the reasons why you are, and it's going to be one of the reasons why you will continue to be. So I was interested in that, and I was interested in the model, the way in which you actually operate, this notion of distributed leadership and this notion of autonomy with localised autonomy. And the reason why I'm interested in that is because if you look across the actually the social political spectrum, there's lots of disruption in there. I mean, I know you don't want me to talk politics. I'm a crossbencher, so I slag them all off, right? But the notion that we are living in very disrupted times, and it feels like the answers aren't coming from anywhere up there. So if you look up, there's not a lot to see. So you have to look out, and the solutions lie very much in local, in communities, in systems, and it's something that I've been very interested in. So I'm interested in the model, I'm interested in the leadership, and I'm interested in where you go next. And just in case you're wondering what I do, I'm here wearing the Turning Point hat, and Martin works, I think it's okay to say that, isn't it? You work for Turning Point. Turning Point provides a service to people at the sharp end of the inverse care law. You all know what the inverse care law is, don't you? In about 200 locations, near as damn it 100,000 people, and our people are, I think it's fair to say, demand drivers. They're the demand drivers in healthcare systems, substance misuse, mental health, learning disabilities, all points in between. They drive the demand. So I've become really quite passionate and interested in the notion of inequality. And as has been said, I spent 6 years on the board of NHS England. There were 3 things that I was interested in, 3 things only. For 6 years I became an absolute nag. Right? One of them was inequality. The fact that we don't talk about it enough. The other was race. We don't talk about that enough, given the numbers of people that are BME working for the NHS, a fundamental challenge. Not just because I'm a 6-foot black guy, because it's a fundamental question for the future of the NHS. And the other was public engagement. So those are the 3 things that I'm interested in. And those are the 3 things that actually are going to pretty much fuel the future of the NHS. But I kind of summarised it in this way. So I'm going to test you now, because I might be wrong, right? Because I know doctors are really keen on slides, and I was a bit worried that I didn't have the sort of slides. You just got me, I'm afraid, and I'm not a doctor, right? So I'm going to try something on you. So I've kind of tried to summarise what the big challenges are facing health and social care systems pretty much everywhere. And I've decided that there are only 3 really big challenges. The first is equity, which isn't the same as equality. So, you've all seen the cartoon, the three guys looking over the fence. The tall guy looks like Rees-Mogg. He gets everybody. There's a really tall guy, average height and then the really small guy. All those of you that know this, you're all nodding. This is for all those that don't, right? And the Rees-Mogg character, they all get an equal size box, right? And the Rees-Mogg character stands on the box. You can see even more over the fence. The average guy just about see over. The poor guy can't see over at all, right? And that is a significant challenge for the NHS. So in London, and you've got equivalent figures for Birmingham, the active life expectancy for a woman in Barking and Dagenham is 53. In Richmond upon Thames it's 71. Now if you don't really care about that because you're kind of morally challenged, that's not the issue, right? Well, I have to ask myself the question, why don't we care about it? And I do question whether the system is morally challenged. But even if you are morally challenged, think about the cost, right? So York University Centre for Health Economics points out quite usefully that the cost of the NHS of A&E visits by poor people is 4.8 billion a year. I think they looked at 17 areas, 4.8 billion a year was the statistic that I used to get Simon's attention and the board's attention on this. That's 25% of the 20 billion we've got. And that's what we know about. Okay, so this is an expensive, immoral challenge, which in my view will crash the NHS if we don't deal with it. Equity. It's the challenge of the NHS. I don't really, my view is, if whatever you're doing doesn't improve equity in provision, why are you doing it? I'm that clear about it. I have no problem saying that. I think it's fundamental, frankly. And I kind of the rationales and the reasons for not doing it tend to be based on an economic model which involves hitting the target but missing the point. And I love economists, but I know this. If an economist was in charge of the NHS in 1948, we wouldn't have it. It makes no sense economically. It only works if you think about it in terms of philosophy and morality. It doesn't work. So we have a problem recognition. So equity, that's the first challenge. The second is access. Now, you can have equity, but if you don't have access, are you still with me? The thing about having all these gongs is that I don't care. I'll just keep talking. The second is access, and access is a real problem. So you can have equity, but if you happen to be a man or woman challenged with substance misuse, and you come to Turning Point's substance misuse service, or anyone's substance misuse service, and you happen to have bronchitis or some other illness that can't be treated in that place, right? And you get referred to your GP, but you don't go to your GP because you're chaotic or you're frightened or both, right? And you're going to end up in A&E. Happens a lot. Happens an awful lot. I've literally watched it. I've watched it happen thousands and thousands of times. Right? Or if you happen to be black and with a mental health challenge and teenager, it's highly likely that you're going to end up, in fact, you're about 8 times more likely if you're in London to end up in a horrible Section 136 place with a good risk actually of being injured. I know that because I did the review of mental health, the Metropolitan Police response to mental health. So it's a serious risk. The access issue breaks down in the following ways. It's about service design. The principle I have of service design is very simple. The point of any service in health and social care is to reduce negative value transfer. You all know what negative value transfer is? Negative value transfer is very simple. Let me explain it in one simple example. You go to your bank, you want to withdraw a tenner. Don't know why I'm staring at you, but let's just stick with it, right? Mm-hmm. You walk into your bank, you want to take a tenner. No cash point, tenner. But you can't take a tenner. You have to go to 10 different cashiers and take £1 each. Right? That's negative value transfer because you've got to spend that time, and furthermore, the bank's employed 10 people when it only needed to 1. That's negative value transfer. Positive value transfer is where you go to one person who gives you the tenner, but also asks you about your financial health. Right? Does as much for you in that transaction as is possible. Right? Basic principle of service design in health and social care, particularly for those at the sharp end in the inverse care law. Do as much as possible for one individual in one place, which is why I was quite pleased when visiting your your primary care service because actually that's what I saw. Positive value transfer. You got everything in one place, right? Basic principle. The third is commissioning. Now, commissioning is often it's misunderstood. I talked to loads of people about commissioning. Everybody's got a different definition. It's like, what is commissioning? It ends up being something other than commissioning, right? It becomes something about purchasing and procurement and contracting, right? And there's a reason why there's different words for those things. Commissioning is not the same as procurement, and it's not the same as contracting. The definition of commissioning that works for me is very simple. Commissioning is the means by which you understand the needs of an individual and or a community such that you can build a platform for procurement. In other words, if you don't understand the needs of that individual and or that community, what the hell are you doing commissioning? Right? And the way you do that, or one of the ways you do that, is through engaging the very people who pay for it all. Right? The point being, the NHS wasn't started by people like us. It was started by people who actually lived in far worse circumstances and, believe me, were far less educated than anyone you've ever met or is likely to meet. Right? The way you understand commissioning is by engaging with the population that you're trying to serve, for which there are four principles. The first is you have to listen, and if I tell you that I'm listening to you, it's meaningless unless you've got evidence that you've been heard. Secondly, there has to be a transfer of power such that the person that you're engaging with is able to do something after the engagement they couldn't do before. Quite difficult for clever people to give up power, but that's what it's about. The third is that the service, at worst, has to be co-produced. At best, it has to be designed by the person who's actually going to receive it. Like, most middle-class people are really insistent upon that. Poor people have been beaten to expect what they're given, which is why they don't go, right, until it's absolutely too late. And the fourth is that the outcome of such a service has to be describable. There's a reason why people go to A&E. It says what it does on the tin. It has to be describable in a sentence by your mother, lover, brother. Yeah? Access. There is a final thing about access, which is workforce design. I used to, you've probably never heard of him, a chap called Solomon J. Rasool, a PhD student, wrote a paper years and years ago, basically describing the future of healthcare professionals as being less bounded by their profession than by the needs of the patient and the community. He talked about people working together across professional boundaries in the interest of positive value transfer. He didn't use that word. If he had it one, he'd have got a better PhD, but there you go. Workforce design. You know, we're not static in our professional boundaries. We are here to serve the public, and therefore we have to change in the interests of their needs rather than ours. Workforce design. That's access. And there's one more, and that is technology. Now, Vish did say that I'm a technology entrepreneur, and I am. I own a company called Visionable, which is a wonderful, wonderful thing. It is a single visual platform for everything in health and social care. So there's lots of visual platforms out there that do bits and things. Ours does everything. The reason why I've never heard of us is because we took 10 years working with people like you and patients to build the platform that actually works. Right? Why is that important? Because technology in healthcare has to serve the first two things I've mentioned, i.e. equity and access. Otherwise it's pointless. It is simply there to either drive shareholder value or impress somebody who is hardly going to use it, or requires them to have a £750 mobile phone. It's not going to work. It might work for a bit. Technology has to serve the first two, otherwise it's pointless, in my view. And given that there are 8 million people who don't have access to technology, that's pretty important in relation to equity and access. Yes? So, I think those are the challenges facing health and social care in this country. Actually, I think it might be bold to say that they're pretty much the challenges facing health and social care anywhere in the Western world. But you might not agree, so I thought I'd throw that out. So, finally, why is it important that you are together as a group in this system and as primary care providers? I have a passion for primary care because I think it's the leading edge of health and social care system, not just now, but way into the future. But the reason why you need to come together and the reason why you need to come together in the way that you have come together, I haven't got time to go into theories of change and how you do how you build successful teams. That's for another time. But I will say this, in my observations of how the health and social care system works, first thing, you won't survive on your own. You just won't. And you certainly won't influence on your own. And you won't be part of change on your own. There are too many big movements. Population health, right, has to work. We've just walked as a system into the Last Chance Saloon and the doors swung behind us. You either lead, follow, or get out of the way. You have to do that collectively, firstly. Secondly, gone are the days of the single influencer of a system, either locally or nationally. You have to influence collectively. You have to build an evidence base, and that's best done by collective effort. It's just, that's the way I see it working. And thirdly, you have to learn on behalf of the system. Now, you've got 470,000 patients and 52 partners. That's right, yes, practices. And you're part of a bigger system. You're not just your system, you're part of a bigger system. And you have to learn on behalf of that bigger system in order to change things. And you can't do that on your own either. So, in conclusion, I would say that you're at the start of something that is really quite powerful, because it started with individuals who were interested in collective effort on behalf of the system, and in particular on behalf of those people at the sharp end of the inverse care law. Right? I always say this to people, as people have heard me speak before will just know that I do speak a lot at things because I'm passionate about this message. But what I do say, and I always say this to people in rooms like this because it's true, really, tomorrow morning you're going to get up and work like dogs, right? On behalf of people who aren't in this room. You are going to do that. Collectively, some of you will contribute to the learning of this OHP thing. But really, every single one of you are change agents on behalf of a system that definitely, absolutely needs change. So I am speaking to some very special people here. Over 1 million people in Birmingham. Some of those people are going to need that change. They're going to need that change, right? And if not now, then when? And if not you, then who? Thank you very much.
Thank you so much, Victor. It's certainly food for thought, inspiration, and kind of pushing us to use the power of the collective that we've formed. What I thought we could do is have the networking session and the question and answers in the informal space. We've got some wine, we've got a bit more food, there's some drinks, and give you a chance to catch up with people and also mingle with the speakers. We've got our partners here, we've got Ardens, we've got Livy, we've got Henson's, and we've got the central team if there are any issues or things that you want to pick up. But just before we do that, we've got some innovators in the room. So please could I just have to the front of the room colleagues from BG Health, MGS, Lordswood and Iridium, and Muchwin, Look and Cressidge, please. If you all want to come up. These are all practices that have said that they are happy to share some of the innovative work that they're doing, sticking their heads above the parapet and giving us some learning to take home with us. Do you want to all come up now? Each and every one of you. Because we'd just like to just recognise that in front of the partnership, that you've taken the time to go above and beyond and share a little. We've got a little certificate of recognition for each of the practices to say thank you for doing that.
And also, what I'd like to do is just recommend that each practice that's here have a few minutes with each of the practices on the screen to just hear a little bit about what they've done, to take a little bit home maybe and to apply, because as Victor said, the change agents are all here in the room. Each of us could be doing some of this back at home, and hopefully next time, you know, we can hear from some more of you as well. So Leslie, do you want to just start giving these out for us? Thank you to each of the practices. Please come and have a chat with them, and likewise have a chat with neighbours and colleagues, and don't forget your feedback. Hopefully there's been a bit of food for thought about where you want to see this organisation that we've created together go in the next 2 to 5 years. Please give us your feedback and enjoy the rest of the evening. Thanks very much.